1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah.
Here, what do the echo people say?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
You know, when you first step into a clinical setting, especially in areas like orthopedics or basic med-surg, there is this, there's certain comfort in the predictability of it all.
Right, absolutely. It's very visible.
Yeah, exactly. A patient comes in with a fractured tibia. The x-ray shows the jagged line, the surgeon sets it, and, well, you just monitor the cast. The pathology is categorized. But stepping onto the labor and delivery floor or into maternal fetal medicine, it completely shatters that illusion of binary medicine.
Oh, it really does. It's a totally different world.
Because you are suddenly navigating this landscape where the physiological baseline is just inherently chaotic. You aren't treating a single patient anymore, right? You are managing this highly volatile shared ecosystem.
A very delicate ecosystem.
Yeah, right, where a totally normal physiological adaptation can just, violently pivot into a catastrophic emergency without a single alarm sounding until it's almost too late.
And that requires a completely different cognitive approach. In obstetric nursing, you are essentially monitoring a state of controlled physiological stress.
Wow, controlled stress. That's a great way to put it.
Yeah, because a pregnant body is already compensating so much. Blood volume has expanded by 50%, cardiac output is massive, and, the immune system is modulated to tolerate a foreign genetic entity. Plus, the kidneys are working in absolute overdrive.
So they are already maxed out.
Exactly. Because the mother is already operating at this extreme physiological maximum, when compensation fails, the crash is spectacular and immediate.
Right.
And that is why OB nursing requires a level of preemptive pattern recognition that goes far beyond just, reacting to vital signs. You have to see the disaster forming in the muddy waters before it breaks the surface.
Which is exactly our mission for this deep dive today. If you are listening to this, imagine we are sitting in the break room right before your shift. You might be deep in the trenches of nursing school, staring down a massive OB exam.
Or maybe prepping for your NCLEX.
Yeah, or perhaps you are a newly minted nurse stepping onto the unit for the very first time. You are here because you want to master obstetric pathology and, you want to pass those exams, absolutely.
But more importantly, you want to be that fiercely safe, elite clinician, the one who catches the subtle drop in the fetal baseline before anyone else.
Exactly, or that slight elevation in maternal blood pressure. So to achieve that, we have to rethink how you study.
Reading clinical textbooks cover to cover is just a recipe for cognitive overload. The human brain cannot prioritize everything equally.
It really can't. So, as your clinical mentors today, we are aggressively applying the Pareto principle to this massive stack of OB pathology sources, guidelines, and clinical notes.
Right, we are sifting through all that noise.
We're going to extract the 20% of high-yield mechanisms, absolute safety priorities, and critical exam traps that will give you 80% of your real-world clinical value and your exam scores.
And we aren't going to just give you dry flashcard definitions. We are going to build your clinical judgment by explaining the why behind the pathology.
Okay, so let's unpack this. We are going to start where every pregnancy starts and track the physiological journey, looking at exactly where the system breaks down.
Makes sense. Start the beginning.
Right. Early on, the fetus isn't viable outside the womb. So our clinical focus, our absolute highest priority, is maternal survival. And the primary threat to maternal survival in the first trimester is hidden, aggressive internal hemorrhage.
Which brings us straight to ectopic pregnancies.
Yes, let's look at ectopics. The high-yield core here is that an ectopic pregnancy is implantation outside the uterine cavity, with 95% occurring in the fallopian tube.
Right, mostly in the tube.
But let's build the pathophysiology for you. If this is just, a fertilized egg stuck in a tube, why is it treated like an absolute ticking time bomb instead of a simple scheduled removal?
Well, to understand the danger, you have to understand the cellular behavior of trophoblasts.
Okay, what are those?
When a sperm fertilizes an egg, the outer layer of cells that forms is called the trophoblast. And these cells are biologically programmed to be highly invasive.
Highly invasive. Okay.
Yeah, their sole mission is to drill into maternal tissue, establish a blood supply, and anchor the pregnancy. They are aggressive.
Wow.
When implantation happens normally in the uterus, the uterine lining of the decidua is thick, vascular, and totally designed to manage and contain this invasion.
But the fallopian tube doesn't have that, does it?
Exactly. The tube has no decidua. It is a thin, delicate, muscular structure designed for transport, not for implantation.
So the embryo gets stuck and those trophoblast cells just start doing what they are programmed to do. They literally start drilling into the wall of the tube.
Precisely. They invade the tubal wall and quickly encounter the maternal tubal arteries. And because the tube isn't built to stretch indefinitely, and because these cells are eating into the vascular supply, the tube will eventually rupture.
And that's the emergency.
It is a massive emergency. When it ruptures, you don't get a slow ooze. You get a massive catastrophic arterial hemorrhage directly into the maternal peritoneal cavity.
Oh, wow. So she's bleeding internally.
Right. The woman can bleed to death internally in a matter of hours. That is the critical why behind the danger. The mortality risk is rapid, profound hypovolemic shock.
Let's translate that to the floor for our listeners. What is the expected presentation versus the concerning presentation? Because early pregnancy involves a lot of weird symptoms anyway.
Yeah, it really does.
Like a patient comes into triage, mild nausea, a missed period, maybe some light cramping. That's totally expected. So how do we spot the ectopic?
The classic clinical triad you will see in triage and constantly on exams, by the way, is a missed period, vaginal spotting, and unilateral abdominal pain.
Unilateral, meaning just on one side.
Yes, unilateral is the key word. It's pain isolated to the side where the tube is affected. But if you are assessing a patient and she suddenly exhibits profound tachycardia, a plummeting blood pressure, pallor, and altered mental status, or syncope beats.
Crashing.
Exactly. She isn't just having a painful pregnancy. Her tube is ruptured. She is in hypovolemic shock, and her peritoneal cavity is filling with blood.
Now, here is a priority nursing action that feels counterintuitive if you don't understand the anatomy. The sources are adamant about this. If you suspect a ruptured ectopic or even an unruptured ectopic, you absolutely must avoid digital vaginal exams.
Yes, absolutely no digital exams.
Walk us through the danger there. Imagine you are a triage nurse, right? The instinct might be to check the cervix or palpate the area.
It's a dangerous instinct in this case. If you palpate the adnexa, that's the area containing the ovaries and fallopian tubes during a bimanual exam, the physical pressure of your fingers can literally be the kinetic force that ruptures a maximally distended tube.
You could cause the rupture yourself.
You could cause the catastrophic bleed right there on the exam table. Therefore, any patient of childbearing age presenting to the ER with abdominal pain gets a urine pregnancy test immediately.
Right, rule out pregnancy first.
Exactly. If it is positive and she has unilateral pain, you keep your hands out of the vagina. You advocate for an immediate transvaginal ultrasound to visualize the location of the gestational sac.
Okay, let's talk treatments. If we catch it early, before it ruptures, we can use medical management. The drug of choice is methotrexate. I want to dig into the pharmacology here because NCLEX loves testing medication mechanisms.
They really do love methotrexate.
Right. Why are we giving a chemotherapy drug to a pregnant woman?
Well, methotrexate is a folic acid antagonist. Folic acid is required for DNA synthesis and cellular replication. By blocking folic acid, methotrexate aggressively targets and destroys rapidly dividing cells.
And those trophoblast cells are dividing super fast.
Exactly. Because those invasive trophoblast cells are dividing faster than almost anything else in the body, the methotrexate halts the pregnancy. This allows the body to resorb the tissue without surgery.
But there are rules for when you can use it, right?
Yes, it only works if the mass is small, usually under 35 millimeters, the tube is intact, and the beta-hCG levels are relatively low.
And if she doesn't meet those criteria, or if the tube is already ruptured?
Then it is a surgical emergency. The patient is rushed to the OR for an exploratory laparoscopy. The surgeon will either perform a salpingostomy, making a linear incision in the tube to carefully remove the pregnancy and attempt to save the tube's function, or a salpingectomy, which is the complete removal of the damaged tube.
And if she is already in hypovolemic shock?
You are simultaneously running 2 large-bore IVs, pushing isotonic crystalloids, and prepping for a massive blood transfusion.
Got it. Okay, let's pivot to the other major first trimester bleeding disaster, the Hydatidiform mole, or molar pregnancy. This is such a fascinating pathology.
It really is wild.
It is an abnormal proliferation of those same invasive trophoblast cells we just talked about. But the sources highlight a major exam trap here, distinguishing between a complete mole and a partial mole. Break down the genetics of this because it explains the entire clinical picture.
This is a massive high-yield exam trap. Let's start with the complete mole, which accounts for about 80% of cases and carries the highest clinical danger.
Okay, complete mole.
In a complete molar pregnancy, an empty egg, an oocyte that has lost its maternal DNA, is fertilized by a sperm. The sperm realizes it's alone and basically duplicates its own chromosomes.
Yeah.
So you have a 46XX karyotype, but every single chromosome is paternal.
There is zero maternal DNA.
Exactly. And because maternal DNA is required to form a fetus, absolutely no embryonic tissue develops. None.
So what grows instead?
The paternal DNA, which drives placental growth, goes into overdrive. The trophoblast cells proliferate wildly into a disorganized, fast-growing mass of swollen, fluid-filled grape-like cysts.
And on an ultrasound, this looks like a snowstorm pattern.
Right. That is your classic memory anchor, complete mole equals grape-like clusters, snowstorm ultrasound, and zero fetal parts.
And what about a partial mole?
A partial mole is usually the result of a completely normal egg being fertilized by 2 separate sperms simultaneously.
So 3 sets of chromosomes.
Yes. This results in triploidy, 69 chromosomes. 69XXX, or XXY, or XYY. Because there's maternal DNA present, some fetal tissue or an amniotic sac actually begins to form, alongside the abnormal cystic placental tissue.
But a triploid fetus can't survive.
No, a triploid fetus is completely non-viable and will succumb early in the pregnancy.
So, clinically, how does a molar pregnancy present differently from an ectopic or a normal pregnancy? Like, if I'm assessing this patient, what are the glaring red flags?
The first major sign is the fundal height. Because this abnormal tissue grows much faster than a normal pregnancy, the patient's uterus will measure significantly larger than expected for her gestational age.
So a woman at 10 weeks might look and measure like she is 16 weeks pregnant.
Exactly. Second, you look at the bleeding. It is often described as dark, reddish-brown vaginal bleeding resembling prune juice.
Prune juice bleeding, got it. And what about her symptoms? I know beta-hCG is the hormone that makes women nauseous in the first trimester. If this tissue is just a massive factory of trophoblast cells, her hCG levels must be completely off the charts.
They are astronomically high. While a normal early pregnancy might have an hCG in the thousands, a molar pregnancy can push hCG into the hundreds of thousands.
That's insane.
It is, and this triggers hyperemesis gravidarum, severe, intractable nausea and vomiting. It can also cause early-onset gestational hypertension or preeclampsia.
Wait, preeclampsia in the first trimester?
Yes, preeclampsia before 20 weeks gestation is almost pathognomonic for a molar pregnancy.
Wow, okay. So the priority action is obviously to evacuate the uterus. The patient will have a suction curettage. But the really heavily tested nursing priority isn't the surgery itself, is it? It's the discharge, teaching, and follow-up.
Yes, the follow-up is critical.
Why are we so intensely worried about a patient who just had the mole removed? I mean, the pregnancy is gone.
We are worried because a molar pregnancy is premalignant. What makes this pathology so dangerous is that up to 20% of complete moles will undergo malignant transformation into a cancer called choriocarcinoma.
Cancer? That's terrifying.
And choriocarcinoma is a wildly aggressive malignancy that loves to metastasize rapidly to the maternal lungs and brain.
So how do we monitor for it to make sure it's not turning into cancer?
We aggressively track the beta-hCG. After the curettage, the patient must have her serum hCG levels drawn weekly until they drop to absolute zero for 3 consecutive weeks.
And after that?
After that, she needs monthly hCG draws for 6 to 12 months. If the hCG levels plateau or start rising again, it means choriocarcinoma is growing. That is exactly right. The strict contraception is mandatory. Now, before we move out of the first trimester, there is one universal priority nursing action that applies to every single bleeding scenario we've discussed. And it's a favorite on pharmacology exams.
Alloimmunization prevention.
Yes. If the mother is Rh negative and she experiences an ectopic pregnancy, a molar pregnancy, a miscarriage, or any trauma, she must receive anti-RHD immune globulin, commonly known as RhoGAM.
Let's break down the why here, because students often just memorize, give RhoGAM at 28 weeks without understanding the mechanism. Why does the mother's blood type matter when she is bleeding?
The rhesus factor is a protein antigen found on the surface of red blood cells. If you have it, you are Rh positive. If you don't, you are Rh negative.
Simple enough.
If an Rh negative mother is carrying an Rh positive fetus, Her immune system has never seen that Rh protein before. It views it as a foreign invader, like a virus or bacteria.
But their bloodstreams don't normally mix, right? The placenta acts as a barrier.
Usually, yes. But during a miscarriage, an ectopic rupture, or normal childbirth, fetal blood cells inevitably mix into the maternal circulation.
And then the mom's immune system spots them.
Right. When the mother's immune system detects those Rh-positive fetal cells, it launches an attack and creates permanent, lifelong antibodies against the Rh antigen. This is called Alloy immunization.
And it doesn't really affect the current pregnancy because the pregnancy is either ending or already over. The danger is to the next pregnancy.
Precisely. The maternal antibodies are IgG, which means they can easily cross the placenta. If she gets pregnant again with another Rh-positive baby, her immune system will send those antibodies across the placenta to actively attack and destroy the new baby's red blood cells.
That sounds devastating.
It causes severe fetal anemia, heart failure, and death, a condition called hemolytic disease of the newborn.
So how does anti-RHD or RhoDGAM prevent this?
Anti-RHD is essentially a dose of synthetic antibodies. When we inject it into the mother, these synthetic antibodies quickly hunt down and destroy any stray fetal Rh-positive cells floating in her bloodstream before her own immune system has a chance to notice them and learn how to make its own antibodies.
So it essentially hides the fetal blood from the maternal immune system.
It's brilliant,
Yeah.
but it only works if given within 72 hours of the bleeding event.
Okay, so if we are condensing this down into a mental flashcard, let's do our 5 absolute must-know takeaways for early bleeding. I'll read them out. 1. Ectopic pregnancies threaten the mother's life through tubal rupture and massive hypovolemic shock.
Absolutely.
2. Never perform a bimanual digital exam on a suspected ectopic patient. 3. A complete molar pregnancy lacks fetal tissue, presents as a snowstorm on ultrasound, and carries a high risk of choriocarcinoma.
Yes, remember the snowstorm.
4. Strict long-term contraception and HCG monitoring are mandatory after a molar pregnancy to detect malignant transformation. And 5. Always administer anti-RHD to an Rh-negative mother experiencing any form of early pregnancy bleeding to protect future pregnancies.
That is exactly how you synthesize the pathophysiology into actionable clinical priorities.
Awesome. Let's follow the chronological progression of the pregnancy. We've survived the precarious first trimester, the fetus is growing, the uterus is expanding, and the placenta is now a massive, fully established vascular organ.
And this changes the landscape entirely.
It really does. When a patient presents with bleeding in the third trimester, the primary culprits shift. We are dealing with the absolute heavyweights of obstetric nursing exams, placenta previa versus placental abruption.
Oh, these are heavily tested.
And we'll also touch on a rare but lethal curveball called vasa previa.
These conditions are the leading causes of massive maternal hemorrhage and acute fetal distress in late pregnancy. Instructors love to test these because they present in starkly different ways, and confusing them in a clinical setting can literally be fatal. Your pattern recognition here must be flawless.
I want to look at the clinical presentation because there is a glaring contrast that always catches students off guard. If both of these conditions involve the placenta bleeding, why is one completely, eerily silent and painless, while the other is agonizingly painful? I mean, it's all just blood, right?
It comes down to anatomical location and the mechanics of tissue stretching versus tissue tearing. Let's look at placenta previa first. The word previa essentially means going before.
Okay.
In a normal pregnancy, the placenta implants high up in the fundus of the uterus, well out of the way. In placenta previa, the placenta implants abnormally low in the uterine cavity, partially or completely covering the internal cervical os, the doorway to the birth canal.
Which is fine when the cervix is locked tight early in pregnancy. But what happens as she approaches term?
Well, in the third trimester, the lower uterine segment naturally begins to thin out, stretch, and soften in preparation for labor. The cervix might begin to imperceptibly dilate.
And the placenta can't stretch like that.
Exactly. As that underlying maternal tissue stretches and shifts, it physically tears away from the rigid, anchored placenta above it.
So the maternal blood vessels connecting the uterus to the placenta are sheared.
Yes. But here is the critical physiological difference. Because the placenta is right over the cervical opening, the blood has an immediate, unobstructed exit route. It flows directly out of the vagina.
It just escapes.
Right. There is no pressure building up inside the uterine cavity. Blood pooling outside the body doesn't hurt. Therefore, The classic hallmark presentation of placenta previa is painless, bright red vaginal bleeding in the second or third trimester.
And her abdomen.
If you lay hands on her abdomen, her uterus will feel soft, relaxed, and completely non-tender.
So our memory anchor here is previa equals painless pooling. Now contrast that entirely with placental abruption.
Abruption is a violent event. It is the premature detachment of a normally implanted placenta. It was high up where it belonged, but something caused it to rip away from the uterine wall before the baby is born.
What causes that?
The leading causes are severe maternal hypertension, blunt force abdominal trauma like a car crash, or profound vasoconstrictors like cocaine use.
And when it rips away, it shears those massive maternal spiral arteries. But unlike previa, the blood doesn't have an easy way out, does it?
Usually it doesn't. The edges of the placenta might remain attached while the center tears away. The maternal blood pumps relentlessly into that space between the placenta and the uterine wall, creating a massive retroplacental hematoma.
So the blood is trapped.
Yes, you have a highly pressurized pocket of arterial blood expanding rapidly inside a closed muscular organ.
And blood is incredibly irritating to muscle tissue, right?
It is intensely irritating. As the hematoma expands and blood infiltrates the myometrial fibers, the uterine muscle reacts violently. It clamps down in a titanic, unyielding contraction to try and tamponade the bleeding vessels. The uterus refuses to relax.
Ow.
Yeah, this causes excruciating, tearing abdominal or back pain.
Which gives us the classic physical exam finding. If you palpate a patient with an abruption, her abdomen won't be soft, it will be rigid, rigid.
The French medical term is uterus en bois, a board-like abdomen.
So the memory anchor is abruption equals agonizing abdomen. But here is a massive exam trap that we have to clarify. Triage nurses often gauge the severity of an emergency by the amount of visible blood on the floor or the sheets. In an abruption, why is relying on visible blood a fatal error?
Because of that retroplacental hematoma, a patient can experience a severe catastrophic abruption where the entire placenta tears away. She bleeds 2 liters of blood internally, and her fetus is completely cut off from oxygen. Yet, because the blood is trapped behind the placenta, there might be absolutely zero visible vaginal bleeding.
Wow, a concealed abruption.
Yes. You must never correlate the volume of external blood with the severity of an abruption. You monitor her vital signs for hypovolaemic shock, tachycardia, hypotension, and you monitor the fetal heart rate for profound decelerations and bradycardia.
Okay, what were the priority nursing interventions for these 2 emergencies? Let's say a patient comes in with painless, bright red bleeding. Previa is suspected. What is the one thing you absolutely do not do?
It is the exact same golden rule as the ectopic pregnancy, but with even higher stakes. You absolutely never perform a digital vaginal exam on a patient with painless third trimester bleeding.
Never, ever.
If you insert your fingers into the cervical canal, you will literally plunge your fingers directly into the highly vascular placental tissue. You will puncture it. You can turn a stable, slow bleed into a catastrophic lethal hemorrhage in a fraction of a second. You diagnose previa solely via ultrasound.
And if an abruption is confirmed, she's writhing in pain, her abdomen is rigid, and the fetal monitor is showing severe late decelerations indicating placental insufficiency.
You are activating a massive transfusion protocol and rushing to the operating room for an emergency crash cesarean section. You need 2 large bore IVs, 16 or 18 gauges. You are drawing blood for a type and cross match, and you are closely monitoring her coagulation labs.
Coagulation labs, like fibrinogen.
Interestingly, yes. The lab value that drops the fastest and correlates closest to the severity of an abruption is maternal fibrinogen. Her body is furiously consuming all of its clotting factors, trying to stop the internal hemorrhage behind the placenta, which puts her at massive risk for disseminated intravascular coagulation, or DIC.
Now, I want to throw a massive curveball into the mix. We've talked about maternal bleeding from the placenta, but there is a third, very rare condition called vasa previa. Explain the anatomy of this, because it sounds like a design flaw in human reproduction.
It truly is a structural anomaly. Normally, the umbilical cord inserts directly into the center of the fleshy placenta, meaning all the fetal blood vessels are protected by Wharton's jelly and placental tissue.
Right, they are safe inside the cord.
But in a condition called a velamentous cord insertion, the umbilical cord inserts into the thin amniotic membranes far away from the placenta. The fetal blood vessels then have to travel totally unprotected, naked, through the fragile membranes to reach the placenta.
And if those naked vessels happen to cross directly over the cervix?
That is vasa previa. You have unprotected fetal arteries and veins resting directly over the internal cervical os. When the mother goes into labor and her water breaks, when the amniotic sac ruptures, those fragile fetal vessels are physically ripped in half.
Oh my God. So the bleeding looks exactly like a placenta previa. It's painless, it's vaginal, it happens suddenly. How on earth does a nurse differentiate the two in the moment?
The timing and the fetal monitor are your only clues if it wasn't caught on a prior ultrasound. Vasa previa bleeding happens exactly at the moment the membranes rupture. And more importantly, the blood being lost isn't the mother's blood. It is the baby's blood.
And a full-term fetus only has roughly 250 to 300 milliliters of blood in its entire body.
Exactly. The mother's vital signs might remain perfectly stable, her heart rate is normal, her blood pressure is fine, but the fetal heart monitor will instantly crash into profound bradycardia or severe variable decelerations.
A baby is bleeding out.
The baby will literally exsanguinate, bleeding to death within minutes. Vasa previa has a mortality rate of over 50% if it isn't diagnosed prior to labor. If it is diagnosed on an early ultrasound, the mother is scheduled for an elective C-section weeks before she ever has the chance to go into labor or have her water break.
Okay, that is incredibly heavy, but absolutely vital to understand. Let's lock in the high-yield takeaways for third trimester bleeding. Number 1, placenta previa presents with painless, bright red bleeding and a soft, non-tender abdomen. Number 2, placental abruption presents with sudden agonizing abdominal pain, a rigid board-like abdomen, and dark red or entirely concealed bleeding.
Crucial distinctions.
Number 3, vasa previa involves the rupture of fetal vessels, presenting as painless bleeding exactly when the water breaks, immediately followed by catastrophic fetal distress. Number 4, never perform a digital vaginal exam on painless third trimester bleeding. You can manually puncture a previa. And number 5, visible blood volume in an abruption does not equal total blood loss. Trust the maternal vitals and the fetal monitor, not your eyes.
Perfect. Those distinctions will guide your clinical judgment and keep your patients safe.
All right, we've established the vascular bleeding risks. Now let's pivot and look at the vascular pressure. We are moving into the hypertensive escalation, tracking a patient from gestational hypertension to preeclampsia to the severe variants of eclampsia and HELLP syndrome.
Hypertensive disorders are one of the leading causes of maternal and perinatal morbidity and mortality worldwide. And it's critical to understand that this isn't a static condition you just medicate and forget. It is a progressive, relentless physiological cascade.
I want to push back on the terminology here to force us to look at the why. If the overarching diagnostic umbrella is hypertension, high blood pressure, why do all the nursing assessments, the protocols, and the exam questions focus so heavily on the mother's urine, her liver enzymes, and her neurological reflexes?
That's a really good question.
Right. If the blood pressure is high, shouldn't we just be looking at the heart and the blood vessels? It feels like we are assessing the entirely wrong organ systems.
That is a brilliant observation, and it highlights the most common misconception about this disease. Preeclampsia is not a disease of high blood pressure. High blood pressure is merely a late-stage symptom of a much deeper systemic whole-body disease.
Wait, really?
Yeah. To understand the labs and the reflexes, you have to look at where the disease actually starts. It starts in the placenta.
Walk me through the pathophysiology. What goes wrong?
In a normal, healthy pregnancy, early in the first trimester, those invasive trophoblast cells we talked about earlier remodel the maternal spiral arteries in the uterus. They break down the muscular walls of those arteries, turning them into wide, low-resistance, floppy pipes.
Okay, to get more blood to the baby.
Exactly. This allows massive amounts of blood to flow easily to the growing placenta without resistance.
But in a patient who develops preeclampsia,
For complex immunological reasons that we still don't fully understand, that vascular remodeling fails. The spiral arteries remain narrow, rigid, and high resistance. Early in the pregnancy, when the baby is tiny, this isn't a problem. But as we cross the 20-week mark and the fetus enters its rapid growth phase, it demands a massive increase in oxygen and nutrients.
and those narrow, rigid pipes simply can't deliver enough blood flow.
Exactly. The placenta becomes ischemic and hypoxic. It is literally starving for oxygen. In response to this severe hypoxic stress, the placenta panics. It begins releasing a massive surge of inflammatory cytokines and anti-angiogenic proteins into the mother's systemic bloodstream.
And what do these placental toxins do to the mother?
They attack the maternal endothelium. The endothelium is the delicate, single-cell inner lining of every single blood vessel in the mother's body. These placental toxins cause profound systemic endothelial dysfunction. The vessels become intensely inflamed, they spasm, they constrict, and crucially, they become leaky.
So the global vasoconstriction and the spasms are what cause the high blood pressure.
Yes, the hypertension is just the mechanical result of all her blood vessels clamping down simultaneously. But the real danger lies in the endothelial damage and the leakiness. Because this is systemic, it attacks every major organ.
Let's look at the kidneys then.
The filtering units in the kidneys become damaged and leaky. Large protein molecules that should be kept in the blood spill out into the urine. That is your proteinuria.
That makes perfect sense. What about the brain?
In the brain, the damaged leaky vessels allow fluid to shift out of the vascular space and into the brain tissue. This causes cerebral edema, brain swelling.
Which causes the headaches.
Yes, this localized swelling is what causes the classic severe, unrelenting frontal headaches, the visual disturbances like seeing flashing lights or scotoma, and the hyperactive deep tendon reflexes.
So when a nurse taps a patient's patellar tendon and their leg violently jerks forward, hyperreflexia, or when you forcibly dorsiflex their foot and it rhythmically beats back down clonus, that isn't a muscle problem. That is an irritable, swollen central nervous system warning you that a seizure is imminent.
Precisely. And if we look at the liver, the endothelial damage causes microclots to form in the hepatic microcirculation. The liver tissue becomes ischemic, inflamed, and swells massively.
And that causes the pain.
This stretching of the liver capsule is exactly what causes the classic right upper quadrant abdominal pain or severe epigastric pain that patients often mistake for intractable heartburn.
Okay, knowing that entire cascade makes the definitions so much easier to understand, let's outline them. Gestational hypertension is simply a blood pressure greater than 140/90 that develops after 20 weeks of pregnancy. But crucially, there is no proteinuria and no evidence of organ damage. The vessels are tight, but they aren't leaking yet.
Right. But if the disease progresses, she crosses the line into preeclampsia. This is defined as a blood pressure over 40/20/90 after 20 weeks, accompanied by either proteinuria greater than 0.3 grams in a 24-hour collection, or are evidence of systemic organ dysfunction, like elevated liver enzymes, low platelets, or cerebral symptoms.
And eclampsia.
Eclampsia is simply preeclampsia that has progressed to the point where the cerebral edema and vasospasms have caused generalized tonic-clonic convulsions, seizures. The brain has essentially short-circuited.
Now, there is a severe variant of preeclampsia that instructors love to test because it requires intensive lab analysis, HELLP syndrome. Break down this acronym for us.
HLLP is an acronym representing the triad of laboratory abnormalities that indicate profound systemic endothelial failure. The H stands for hemolysis.
Red blood cells breaking down.
Right. As red blood cells are forced through those highly constricted, damaged, inflamed maternal blood vessels, they are physically shredded by fibrin strands. They are sheared apart. If you look at a blood smear, you will see fragmented red blood cells called schistocytes.
So the mother is becoming acutely anemic because her own blood vessels are destroying her red blood cells. What about the EL and LP?
EL stands for elevated liver enzymes. Remember the ischemic swollen liver we discussed? As the liver cells die from lack of oxygen, they burst open, spilling enzymes like AST and ALT into the bloodstream.
And LP?
LP stands for low platelets or thrombocytopenia. The mother's body recognizes the widespread damage to the blood vessel linings across her entire body and deploys all of her platelets to try and patch the microscopic holes. She consumes her entire platelet supply, drastically increasing her risk for a catastrophic hemorrhage.
Let's talk exam traps regarding HLP syndrome, because this is where clinical judgment is critical. A triage nurse might look at a patient, see a totally normal blood pressure, and assume she can't have a hypertensive disorder.
That is a fatal exam trap. HLLP syndrome is insidious. In up to 20% of HLLP cases, the mother may present with completely normal blood pressure and absent proteinuria.
So you wouldn't even know just by looking at her vitals.
Right. She might walk into triage complaining only of right upper quadrant pain, severe nausea, and feeling unwell. If you brush her off because her BP is 20/20/80, she could seize or hemorrhage within hours. You must look at the labs. If her platelets are tanking and her liver enzymes are skyrocketing, she has HLLP syndrome, regardless of the blood pressure.
Let's discuss priority nursing interventions. Let's say a patient with severe preeclampsia crosses the threshold. She begins to actively seize. Eclampsia. What is the step-by-step nursing priority?
In any seizure, OB or otherwise, your absolute first priority is always the maternal airway. You must protect her airway and prevent aspiration.
Do we turn her on her side?
Yes. You immediately turn her into the recovery position, ideally a left lateral tilt to shift the weight of the gravid uterus off the inferior vena cava, which maintains cardiac return. You call for help, apply oxygen via non-rebreather mask, and have suction ready.
Once the airway is secure and the immediate physical danger is managed, we reach for the most important medication in the OB crash cart: magnesium sulfate. This drug is heavily tested. What is the mechanism of action, and what is the massive misconception students have about it?
The massive trap is thinking that magnesium sulfate is an antihypertensive drug. It is not. We do not give it to lower blood pressure.
Oh, wow, okay.
Magnesium sulfate is a potent central nervous system depressant and smooth muscle relaxant. It works by competing with calcium channels in the central nervous system, effectively blocking the neuromuscular transmission that causes seizures. It raises the seizure threshold. We give it solely to prevent seizures in severe preeclampsia or to stop active seizures in eclampsia.
It might cause a slight transient dip in blood pressure simply because it relaxes smooth muscle. But if a patient's blood pressure is sitting at a stroke level, 180/110, magnesium won't fix that.
Exactly. If you need to acutely lower a critically high blood pressure to prevent a maternal hemorrhagic stroke, you must administer targeted, fast-acting antihypertensives. The heavy hitters in OB are IV labetalol, which is a beta blocker, IV hydralazine, a direct vasodilator, or oral nifedipine, a calcium channel blocker. You give the MAG for the brain, you give labetalol for the blood pressure.
Now, magnesium sulfate is a high-alert medication. It has a very narrow therapeutic window. If we give too much, we don't just stop the seizures, we stop everything. What are the signs of magnesium toxicity that a nurse must vigilantly monitor for?
You are monitoring for the progressive loss of neuromuscular function. The very first sign of toxicity is the loss of deep tendon reflexes. The patellar reflex will disappear.
And then breathing.
As levels rise further, smooth muscle paralysis hits the lungs, leading to severe respiratory depression. A respiratory rate under 12 breaths per minute is a massive red flag. Finally, it causes profound oliguria, dropping urine output below 30 milliliters per hour and eventually cardiac arrest.
And the antidote. If you walk into a room and your patient on a magnesium drip is unresponsive with a respiratory rate of 8.
You immediately stop the infusion and you push the antidote, calcium gluconate. Calcium directly antagonizes the magnesium at the receptor sites, instantly reversing this central nervous system depression. You must always have calcium gluconate drawn up and ready at the bedside when running a magnesium drip.
We've covered a massive amount of pathophysiology here. What is the ultimate cure for this entire disease cascade?
Delivery. The placenta is the source of the anti-angiogenic toxins. The only way to stop the endothelial destruction is to deliver the baby and remove the placenta from the mother's body.
Which leads to one final critical exam trap. Once the placenta is delivered, is the mother instantly safe?
Absolutely not. And this is where postpartum nurses must be hypervigilant. It takes time for the maternal body to clear those circulating placental toxins and for the endothelium to heal. Preeclampsia, eclampsia, and HELLP syndrome can trigger or severely worsen up to 48 to 72 hours after delivery.
Wait, really? After she's delivered?
Sometimes even up to a week postpartum. You must continue strict blood pressure monitoring and neurological assessments on the postpartum floor. Do not let your guard down just because the baby is in the bassinet.
All right, let's distill the hypertensive escalation into our high-yield clinical takeaways. 1. Preeclampsia is not just high blood pressure. It is systemic endothelial damage causing leaky vessels, proteinuria, and organ swelling. 2. Right upper quadrant pain and severe, unrelenting headaches are glaring red flags for impending eclampsia or HELLP syndrome. 3. Magnesium sulfate is administered to raise the seizure threshold, not to lower blood pressure. 4. Monitor diligently for magnesium toxicity, loss of reflexes, respiratory depression, and decreased urine output, and always have calcium gluconate ready. And 5. HELLP syndrome can present with completely normal blood pressure. Always rely on your lab values for hemolysis, liver enzymes, and platelets.
Excellent synthesis. Understanding that progression will save you on countless prioritization and delegation questions.
Let's shift our focus inward. We've managed the bleeding, we've managed the vascular pressure. Now we need to look at the actual physical environment the fetus is living in. Segment 4 is all about the container, the cervix, and the fluid inside the amniotic sac. Let's start with the structural integrity of the container. The outline discusses cervical insufficiency. This is defined as painless dilation of the cervix without uterine contractions, typically occurring in the second trimester, around 14 to 20 weeks. How does this happen? The cervix is supposed to be locked tight until term?
The cervix is essentially a dense, muscular, collagen-rich ring designed to act as a physical load-bearing barrier. However, Some women have structural weaknesses in that collagen matrix.
Like from genetics.
This can be congenital or, much more commonly, it is acquired through previous cervical trauma. If a woman has had a lick procedure or a cone biopsy to remove abnormal cervical cells or multiple D&C procedures, the structural integrity of the cervix is permanently weakened.
So as the pregnancy enters the second trimester and the fetus and the amniotic fluid start to rapidly gain mass, the weakened cervix simply cannot handle the increase in gravitational weight.
Exactly. It doesn't contract, it doesn't cause labor pains, it simply gives way. It silently, painlessly dilates and effaces.
That's awful.
Often the first sign a woman has is a feeling of pelvic pressure, or she might notice a change in vaginal discharge. By the time it is discovered, the amniotic membranes might literally be bulging through the open cervix into the vaginal canal. It is a leading cause of mid-trimester pregnancy loss.
What are the priority nursing actions and medical interventions if this is caught early, say on a routine 16-week transvaginal ultrasound that reveals a shortening cervical length?
If the cervix is shortening but hasn't fully opened, we can use prophylactic vaginal progesterone, which helps maintain uterine quiescence and cervical length. But the definitive mechanical treatment is a surgical procedure called a cervical cerclage.
A cerclage is literally sewing the cervix shut, right? Like a purse string suture around the opening.
Yes, a heavy suture is placed around the cervix to physically bind it closed and support the weight of the pregnancy. It is usually placed around 12 to 14 weeks prophylactically for women with a known history, or as an emergency rescue procedure if dilation has already begun.
Now, instructors love to test contraindications. When can you absolutely not place a cerclage?
You cannot place a cerclage if the patient is experiencing active vaginal bleeding, if she is having true preterm contractions, or if there is any sign of an intrauterine infection like chorioamnionitis.
Why not during contractions?
If she is already in active labor, stitching the cervix closed will cause the uterus to rupture against the suture. And if she's infected, sewing the cervix shut simply traps a legal infection inside the uterus with the baby.
Speaking of true preterm contractions, let's clarify a massive clinical distinction. How do we differentiate Braxton Hicks contractions from true preterm labor? A patient comes into triage at 30 weeks complaining of cramping. How do we know if she's actually laboring?
This is a fundamental OB nursing concept. Braxton Hicks contractions are disorganized practice contractions. They might be uncomfortable, but they're typically irregular. They often stop if the patient changes position or drinks a large glass of water, and critically, they do not cause the cervix to change.
And true labor?
True preterm labor involves regular, increasingly intense contractions that do not subside with hydration or rest, and they cause progressive cervical dilation and effacement.
And we evaluate that using a transvaginal ultrasound to measure cervical length.
Yes. If a patient is contracting, but her cervical length remains solidly above 30 millimeters, the statistical chance of her actually delivering in the next week is less than 3%. We can usually hydrate her and send her home. But if that cervix is shortening below 25 millimeters and funneling, she is in true preterm labor and requires aggressive intervention.
Let's talk about the fluid environment itself. The amniotic fluid. We are looking at oligohydramnios, which is too little fluid, and polyhydramnios, which is too much. Let's start with the pathophysiology of the fluid itself. Where does amniotic fluid come from in the second half of pregnancy?
In the first trimester, the fluid is mostly derived from maternal plasma crossing the fetal membranes. But by the second half of pregnancy, amniotic fluid is almost entirely composed of fetal urine.
Wait, it's just urine?
Mostly, yes. The fetus swallows the fluid, processes it through its gastrointestinal tract, filters it through its kidneys, and urinates it back into the amniotic sac. It is a continuous, dynamic recycling system.
So the volume of fluid is a direct reflection of fetal physiological well-being. Let's look at oligohydramnios. This is defined as less than 500 milliliters of fluid, or an amniotic fluid index of less than 5 centimeters on ultrasound. I like the memory anchor oligo equals squished. If the fluid is fetal urine and there is almost no fluid, that means the baby isn't urinating. Why?
There are two main reasons. The first is a structural fetal anomaly. The baby might have renal agenesis, missing kidneys, or severe urinary tract obstructions preventing urine output. The second, and much more common reason, is severe placental insufficiency.
Like we discussed with chronic hypertension or preeclampsia, the placenta isn't working.
Right. If the placenta is failing and not delivering enough oxygenated blood, the fetus triggers a survival reflex. It aggressively shunts whatever highly oxygenated blood it has directly to its brain and its heart, bypassing non-vital organs like the gut and the kidneys. Less blood perfusing the kidneys means drastically reduced glomerular filtration, which means no urine output, resulting in severe oligohydramnios.
And the physical danger to the baby of being squished.
Without the buoyant cushion of amniotic fluid, the umbilical cord becomes highly vulnerable. Every time the mother moves or the uterus contracts, the cord gets physically compressed between the fetal body and the uterine wall. This pinches off the blood supply, leading to sudden drops in the fetal heart rate, which you will see on the monitor as severe variable decelerations.
Now let's look at the opposite extreme polyhydramnios. An amniotic fluid volume greater than 2,000 milliliters, or an AFI over 24 centimeters. The memory anchor here is poly equals overinflated balloon. If there is too much fluid, the baby is peeing too much. Why?
The single most common cause is poorly controlled maternal gestational diabetes. Maternal hyperglycemia leads to fetal hyperglycemia. The excess sugar acts as an osmotic diuretic in the fetal kidneys, causing massive fetal polyuria.
So the baby pees constantly?
Yes, filling the uterus like a water balloon. Another cause is fetal swallowing defects. If the baby has esophageal atresia or anencephaly, it cannot swallow the fluid to recycle it, so it just accumulates.
And what is the danger to the mother of this overinflated balloon scenario?
The massive overstretching of the uterine muscle fibers. During labor, an overdistended uterus is prone to dysfunctional, weak contractions. But the real danger is postpartum. Once the baby is delivered, that exhausted, overstretched myometrium struggles to clamp back down. Uterine is the leading cause of massive postpartum hemorrhage, and polyhydramnios is a primary risk factor for it.
Let's discuss the ultimate disruption of the fetal environment PPROM, preterm pre-labor rupture of membranes. The water breaks before 37 weeks and before contractions have even started. Imagine a patient at 30 weeks comes into triage. Fluid is leaking down her legs. My immediate question is, if the sterile protective sac is broken, shouldn't we just induce labor and deliver the baby right now to be safe? Why do the protocols discuss watchful waiting or expectant management?
It is one of the most difficult balancing acts in obstetrics. You are constantly weighing two incredibly dangerous opposing risks against each other.
Prematurity versus infection, right?
Exactly. On one hand, you have the risk of extreme prematurity. A baby born at 30 weeks faces severe respiratory distress syndrome, intraventricular hemorrhage in the brain, and necrotizing enterocolitis. We want to keep the baby inside to mature if possible.
But on the other hand, the physical barrier protecting the baby from the outside world is gone.
Exactly. The vagina is teeming with naturally occurring flora. Once the amniotic sac ruptures, those bacteria have a direct, unimpeded highway straight up into the uterine cavity. The longer the water is broken, the exponentially higher the risk of a severe, life-threatening intrauterine infection called chorioamnionitis. So we watchfully wait, hoping to gain days for the fetal lungs to mature, while aggressively monitoring for any subtle sign of infection.
What are the expected findings of PPROM versus the alarming, concerning findings that mean the waiting is over?
We expect a continued trickle of clear amniotic fluid, but the alarming signs of ascending infection are maternal fever, uterine tenderness upon palpation, malodorous or purulent vaginal discharge, and elevated maternal white blood cell count.
What about the baby?
That's the key. The most critical, often the absolute earliest warning sign of chorioamnionitis, is fetal tachycardia. The baby's heart rate will jump above 160 beats per minute long before the mother ever spikes a fever. If you see infection, the watchful waiting ends immediately. You must deliver the baby regardless of gestational age and initiate broad-spectrum 5E antibiotics.
Let's outline the priority nursing actions when that 30-week patient first walks into triage with suspected PPROM. We talked about avoiding digital exams with bleeding. Is it the same rule here?
It is the exact same rule, but for a different physiological reason. With PPROM, you absolutely must avoid digital vaginal exams to minimize the introduction of bacteria.
Because you could push bacteria up there.
Yes, every time a provider inserts their fingers into the cervix to check dilation, they are physically acting as a plunger, pushing vaginal bacteria directly up toward the unprotected fetus.
So how do you confirm her water broke if you can't check her?
You perform a sterile speculum exam. You visually inspect the vaginal vault for pooling of clear fluid. You can perform a nitrazine test, where the paper turns deep blue, indicating the alkaline pH of amniotic fluid, or a Fern test, looking at the dried fluid under a microscope.
Any exam traps here?
Yes, a highly testable exam trap. Never use standard surgical lubricant on the speculum during a PPROM evaluation. Lubricant can alter the pH and cause a false positive nitrazine result, or disrupt the ferning pattern. You use sterile water only.
If the tests are positive and there is no sign of infection yet, we initiate expectant management. What pharmacology are we deploying to protect this premature baby while we wait?
First, we administer a course of intramuscular corticosteroids, typically betamethasone or dexamethasone. This is crucial for pregnancies under 34 weeks. The steroids cross the placenta and massively accelerate fetal lung maturity by stimulating the production of surfactant.
Which helps them breathe.
Right. Surfactant keeps the tiny alveoli in the baby's lungs from collapsing after birth, drastically reducing the severity of respiratory distress syndrome. We administer a prophylactic 7-day course of broad-spectrum antibiotics, like ampicillin and azithromycin, to delay the onset of infection and prolong the latency period. We may also initiate a magnesium sulfate infusion, but in this specific scenario, it is not for maternal seizures.
What is it for then?
For pregnancies under 32 weeks, magnesium sulfate provides profound fetal neuroprotection, significantly reducing the incidence and severity of cerebral palsy in very preterm infants.
The pharmacology in OB is truly incredible in how it multitasks. Let's lock in our high-yield clinical takeaways for the fetal environment. 1. Cervical insufficiency is silent, painless dilation in the mid-trimester. Cerclages are contraindicated if there is active bleeding or infection. 2. Oligohydramnios indicates placental insufficiency or fetal renal anomalies and poses a severe risk for umbilical cord compression.
Spot on.
3. Polyhydramnios is driven by fetal polyuria, often due to maternal diabetes, and puts the mother at massive risk for postpartum hemorrhage due to uterine overstretching. 4. PPROM requires balancing prematurity against infection. Fetal tachycardia is often your very first warning sign of chorioamnionitis. And 5. Absolutely no digital vaginal exams with suspected PPROM to prevent pushing bacteria up to the baby. Use a sterile speculum with water, no lubricant.
Excellent. The physiological why behind those rules makes them impossible to forget.
Moving right along, let's explore what happens when the fetal environment is shared or when the placenta fundamentally fails to provide adequate nutrition. We are diving into multiples and fetal growth restriction. Let's start with twins. The sources heavily emphasize that multiple gestations are automatically categorized as high-risk pregnancies.
They absolutely are. Human reproductive anatomy and physiology evolved to optimize the carrying of a single fetus. When you introduce a second fetus, the physical and metabolic demands on the maternal system double.
Which leads to more complications.
Yes. The rates of every major complication, preeclampsia, gestational diabetes, preterm labor, PPROM, and postpartum hemorrhage skyrocket.
To understand the specific risks, we have to understand chorionicity. The outline divides twins into dichorionic and monochorionic. What does this mean structurally?
The chorion is the outer membrane that eventually forms the fetal portion of the placenta. So chorionicity simply refers to how many placentas there are. Dichorionic means there are two entirely separate placentas.
Like fraternal twins.
Yes, this happens in dizygotic or fraternal twins, where two separate eggs are fertilized by two separate sperm. They implant independently and grow their own support systems.
And monochorionic.
Monochorionic means they share one single placenta. This occurs exclusively in monozygotic or identical twins when a single fertilized egg splits into two embryos relatively late, between days 4 and 8 after fertilization. Because they split late, they are stuck sharing a single life support system.
And sharing a single placenta is where the profound, unique danger lies, specifically regarding a condition called twin-to-twin transfusion syndrome, or TTTS. Walk us through the pathophysiology of this.
TTTS occurs exclusively in monochorionic twins. Because they share a single placenta, their individual vascular networks often cross paths on the surface of the placental disc. Arteries from one twin can connect directly to veins of the other twin.
Like little bridges.
Right. These connections are called arteriovenous anastomoses. In most shared placentas, the blood flow back and forth across these connections remains relatively balanced. But in PTTS, the flow becomes catastrophically unbalanced.
It becomes a one-way street.
Exactly. Blood from one twin, designated as the donor, is continuously shunted away and pumped directly into the circulatory system of the other twin, designated as the acceptor or recipient.
Now, conceptually, if the acceptor twin is getting all this extra blood, extra nutrients, and extra oxygen, shouldn't they be the massive, thriving, incredibly robust twin, while the donor is just small and frail?
Intuitively, you would think so.
Yeah.
But the physiological reality of volume overload is brutal. The acceptor twin is not thriving. They're quite literally drowning in excess volume.
Oh, wow.
Their tiny fetal heart is not designed to pump that massive amount of highly viscous blood. The extreme hypovolemia causes their heart to undergo massive hypertrophy. It enlarges and eventually fails. Furthermore, to try and offload all this excess fluid, The acceptor's kidneys go into overdrive, resulting in massive polyuria and severe polyhydramnios.
So the acceptor is huge in profound heart failure and swimming in an overinflated amniotic sac. What happens to the donor?
The donor is being systematically drained. They develop profound hypovolemia. Their blood pressure plummets. To preserve blood flow to their brain, they vasoconstrict blood flow to their kidneys.
Which means no urine.
Right. Their kidneys essentially shut down. They stop producing urine entirely, leading to severe oligohydramnios. On ultrasound, the donor is severely growth-restricted, deeply anemic, and because there is no amniotic fluid, they get shrink-wrapped in their own amniotic membrane and plastered against the side of the uterine wall.
That's horrifying.
Yeah, sonographers literally refer to it as the stuck twin.
Our memory anchor here is vivid. The TTTS donor is dry and stuck, while the acceptor is drowning in volume overload and heart failure. What is the treatment for this? Because without intervention, the mortality rate is near 90%.
If caught early via intensive, frequent ultrasound monitoring, specialized maternal fetal medicine surgeons can perform a fetoscopic laser photocoagulation. They insert a tiny laser through the mother's abdomen into the uterus, locate those abnormal communicating blood vessels on the surface of the placenta, and physically burn them shut, permanently separating the two fetal circulations.
That is mind-blowing medicine. Let's shift from shared placentas to failing placentas in singleton pregnancies. Fetal growth restriction, or FGR. The baby is measuring significantly below the 10th percentile for gestational age. The outline breaks this down into two distinct types, symmetrical and asymmetrical FGR. These have totally different timelines and totally different causes.
Yes, differentiating between symmetrical and asymmetrical growth restriction is highly testable because it points directly to the underlying etiology. Let's look at symmetrical FGR first.
Okay, symmetrical.
In symmetrical, the entire body of fetus is proportionally small. The head circumference, the abdominal circumference, the femur length, everything is equally undersized.
Why does that happen?
This type of restriction begins very early in the first trimester, during the cellular hyperplasia phase, when the baby is rapidly creating new cells. If an insult occurs during this phase, the baby simply cannot generate enough cells to grow to a normal size.
What kind of insult?
The primary causes are intrinsic to the fetus: severe chromosomal abnormalities, genetic syndromes, or early, devastating intracellular infections known as torchich infections, like cytomegalovirus, rubella, or toxoplasmosis. The fetus just has limited growth potential from the very beginning.
Now, asymmetrical FGR is much more common. How does this present, and what is the underlying mechanism?
Asymmetrical FTR occurs much later in the pregnancy, typically in the late second or third trimester. The baby was growing perfectly normally, generating a normal amount of cells, but then the environment failed. The primary culprit is severe placental insufficiency.
Caused by things like high blood pressure.
Right, often caused by maternal chronic hypertension, severe preeclampsia, or heavy maternal smoking. The placenta's vascular bed becomes degraded and calcified. It simply cannot deliver enough oxygen and nutrients to sustain normal growth.
So how does the fetus adapt to this starvation?
The fetal physiological response is incredibly sophisticated. The fetus recognizes the profound hypoxia and triggers a survival mechanism known as the brain-sparing reflex.
Brain-sparing?
Yes. It aggressively vasoconstricts the blood vessels, feeding its liver, its gut, and its skeletal muscles. It takes every single available drop of highly oxygenated blood and shunts it directly to the brain, the heart, and the adrenal glands to keep the vital organs alive.
Which explains the physical asymmetry on the ultrasound.
Exactly. Because the blood is shunted away from the liver stops growing, and the fetal glycogen stores are depleted. So the abdominal circumference measures drastically small. But because the blood was shunted to the brain, the head circumference continues to grow relatively normally. You end up with a baby that has a normal-sized head, but a tiny, severely wasted body.
What are the priority nursing actions when monitoring a fetus with severe asymmetrical FGR?
Because placental insufficiency can deteriorate rapidly into sudden intrauterine fetal demise, these patients require intense surveillance. We use Doppler ultrasounds to measure the blood flow velocity in the umbilical artery and the fetal middle cerebral artery.
And what are we looking for?
If we see absent or reversed end-diastolic flow in the umbilical artery, it means the placenta is failing completely, and we must deliver the baby immediately, usually via C-section, regardless of prematurity.
There is a terrifying maternal complication related to severe fetal distress or impending demise that I want to highlight because it demonstrates the physical connection between mother and baby perfectly. Mirror syndrome. What is this?
Mirror syndrome, or Ballantyne syndrome, is a rare but profound physiological phenomenon. It occurs when a fetus develops hydrops fetalis, which is severe, generalized swelling and heart failure, often seen in the TTTS acceptor twin or in cases of severe fetal anemia like RA alloimmunization.
Okay, so the baby is swelling.
As the fetus spirals into massive fluid overload and heart failure, the mother's body actually begins to mirror the dying fetus.
The mother starts swelling.
Yes, the mother rapidly develops massive generalized edema, severe hypertension, and pulmonary edema that directly mimics the baby's hydrops. The exact mechanism isn't fully understood, but it's believed that the massive placental dysfunction forces the mother's cardiovascular system to essentially try and share the burden of the failing fetal heart. It is a critical maternal emergency, and the only cure is the immediate delivery of the fetus.
It is the ultimate example of a shared physiological ecosystem. Let's summarize the high-yield core for multiples and growth. 1. Monochorionic twins share a single placenta and are uniquely at risk for vascular complications like TTTS. 2. In TTTS, the donor twin is profoundly hypovolemic, presenting with oligohydramnios. They are dry. 3. The TTTS acceptor twin is severely hypervolemic, facing massive cardiac overload and polyhydramnios. They are drowning. 4. Symmetrical FGR is a proportional restriction starting early in pregnancy, usually caused by chromosomal defects or torsoch infections. And 5, asymmetrical FGR is a late-stage restriction caused by placental insufficiency, where the fetus initiates a brain-sparing reflex, resulting in a normal head size but a wasted abdomen.
Those pathophysiological distinctions are the key to answering any exam question on fetal growth.
We have arrived at our final clinical segment. We've examined the uterus, the placenta, the amniotic fluid, and the fetal growth patterns. Now we pull the lens all the way back to look at what flows through the mother's entire systemic circulation. We were talking about systemic stressors, gestational diabetes, severe hepatic conditions, and the catastrophic impact of external substances like cocaine and tobacco.
These are the systemic catalysts. A maternal metabolic or vascular disruption here is what triggers almost all of the downstream disasters, the abruptions, the polyhydramnios, the fetal growth restrictions that we've already covered today.
Let's start with gestational diabetes mellitus, or GDM. The pathophysiology of GDM centers around human placental lactogen creating maternal insulin resistance, causing her blood sugar to rise. We know that this excess sugar crosses the placenta, overfeeds the baby, and leads to macrosomia, a massive baby weighing over 4,000 grams.
Right, big babies.
That causes obvious mechanical risks during vaginal delivery, like shoulder dystocia. But my clinical question focuses on the immediate postpartum period. If this baby has been living in a high-sugar environment for months, why is the single biggest physiological risk to the newborn after birth hypoglycemia? Shouldn't the baby be completely sugar-loaded?
It is a brilliant question, and understanding the insulin dynamics here is crucial for neonatal nursing. While maternal glucose freely crosses the placenta and enters the fetal circulation, maternal insulin is a massive molecule that absolutely does not cross the placenta.
So the fetus is receiving a massive continuous influx of maternal sugar, but it has no maternal insulin to help process it.
Correct. The fetus is entirely on its own to manage this extreme glycemic load. In response, the fetal pancreas goes into massive hyperdrive. The beta cells in the fetal pancreas physically undergo hypertrophy. They enlarge and begin pumping out astronomical amounts of endogenous fetal insulin to force all that sugar into the fetal cells.
And as a side note, insulin acts as a primary growth hormone in fetal development, which is precisely why the baby gets so incredibly large.
Exactly. So you have a macrosomic baby whose pancreas is accustomed to churning out massive doses of insulin, 247, to combat the maternal sugar supply. Now imagine the moment of birth. The baby is delivered, and the provider clamps and cuts the umbilical cord.
The maternal sugar supply is instantly severed.
It is cut off completely. But the baby's hypertrophied pancreas does not have an off switch. It doesn't know the cord has been cut. It continues to wildly pump out massive amounts of insulin into the newborn's bloodstream.
And without the maternal sugar to balance it, that massive insulin surge instantly devours whatever small glycogen stores the newborn has left.
Precisely. The newborn's blood sugar plummets to critical, life-threatening levels within the first hour of life. Neonatal hypoglycemia can cause profound lethargy, jitteriness, temperature instability, respiratory distress, and eventually devastating neurological damage and seizures.
So the priority nursing action on the postpartum floor for a GDM baby is aggressive. Scheduled monitoring of the neonate's heel stick blood glucose levels, starting within 30 minutes of birth.
Yes.
And the primary intervention is early, frequent feeding, preferably initiating breastfeeding immediately in the delivery room to provide an exogenous glucose source to counteract that insulin crash.
Is exactly right. Next, let's examine two maternal liver conditions that instructors love to compare because they sound somewhat similar. Both cause nausea, but they have vastly different clinical implications and mortality profiles. Acute fatty liver in pregnancy, or AFLP, and intrahepatic cholestasis of pregnancy, or ICP.
How do we differentiate these in a clinical vignette? What is the core difference?
The exam trap here is confusing the two based on mild symptoms, but you have to look at who is actually dying. In acute fatty liver of pregnancy, the mother is critically visibly sick. Due to a mitochondrial defect in processing fatty acids, microscopic fat droplets infiltrate and destroy the maternal liver cells. The liver essentially goes into rapid fulminant failure.
What are the clinical signs?
She will present with severe abdominal pain, intractable vomiting, and rapid onset jaundice. If you look at her labs, she will have profound hypoglycemia, severe coagulopathies, and drastically elevated liver enzymes.
Sounds incredibly dangerous.
It is. AFLP carries a massive risk of maternal mortality. The definitive immediate treatment is the delivery of the fetus and transferring the mother to an intensive care unit.
Okay, so AFLP equals profound maternal liver failure. What about cholestasis, ICP?
In cholestasis, if you look at the mother, she physically appears completely fine. Her basic liver enzymes might only be slightly elevated, and she usually isn't jaundiced. Her primary and often her only symptom is intense, maddening, unrelenting pruritus itching.
Where does it itch?
Specifically, she will complain of severe itching on the palms of her hands and the soles of her feet, which becomes drastically worse at night.
Now, pregnant women get itchy all the time because their skin is stretching, and the outline mentions a condition called polymorphic eruption of pregnancy, or PE, which also causes intense itching. How do we differentiate these?
PEP, or other gestational dermatoses like pemphigoid gestationis, present with an angry, visible, blistering, or bumpy rash, usually starting on the abdomen near the stretch marks. In cholestasis, there is absolutely no rash. The skin looks entirely normal, save for the scratch marks the mother makes herself.
Okay, so she has incredibly itchy palms and soles with no rash. That sounds incredibly annoying for the mother, but it doesn't sound like a medical emergency compared to acute fatty liver.
To the mother, it is just sleep-depriving and annoying, but to the fetus, it is highly lethal. Cholestasis is a functional impairment of bile flow out of the liver. Because the bile can't exit normally, bile acids build up to toxic levels in the maternal bloodstream. These bile acids easily cross the placenta and enter the fetal circulation.
And what do bile acids do to the fetus?
High levels of bile acids are intensely directly toxic to fetal cardiomyocytes, the muscle cells of the fetal heart. They disrupt the electrical conduction pathways. This can trigger sudden, entirely unpredicted, catastrophic fetal arrhythmias, leading to sudden intrauterine fetal demise.
A baby can just pass away like that.
Yeah. A baby that looked perfectly fine on a monitor an hour ago can suddenly suffer cardiac arrest.
So in AFLP, the mother is dying of liver failure, but in cholestasis, the mother is just itchy, while the fetus is at risk of sudden cardiac death.
Exactly. That is the critical distinction. The priority nursing action for a mother complaining of itchy palms is to immediately draw serum fasting bile acid levels. We treat the mother with a medication called ursodeoxycholic acid, which helps bind and clear the bile from her blood.
And the birth plan.
Because the risk of sudden stillbirth increases exponentially as term approaches, the standard obstetric care is a proactive induction of labor, typically around 36 or 37 weeks, to get the baby out before the bile acids trigger a cardiac event.
That is fascinating and terrifying. For our final topic, let's look at the impact of external substances, specifically cocaine and tobacco. We all know smoking is detrimental to a pregnancy, but from a strict pathophysiological standpoint, what are these specific drugs doing to the uterine environment?
Both cocaine and the nicotine in tobacco are incredibly potent systemic vasoconstrictors. When a mother uses these substances, they cause violent, sustained clamping down of the blood vessels.
Including the delicate spiral arteries feeding the placenta.
Exactly. If we look at chronic use, like heavy daily smoking, the constant vasoconstriction means the placenta is perpetually underperfused, is chronically starved of oxygen. This leads directly to the severe placental insufficiency and the asymmetrical fetal growth restriction, the brain-sparing, wasted body babies that we discussed in the last segment.
And what about acute use, particularly with a potent sympathomimetic like cocaine?
The acute danger is catastrophic. A sudden, Violent vasospastic surge from a hit of cocaine causes the vascular bed underneath the placenta to wildly contract. This kinetic shearing force can literally rip a completely healthy, normally implanted placenta right off the wall of the uterus.
Tearing it completely off.
Cocaine use is one of the leading, most heavily tested triggers for a massive, acute placental abruption.
Which brings our deep dive full circle right back to the agonizing board-like abdomen and the concealed hemorrhage we started with. Let's wrap up this final section with our 5 high-yield takeaways. 1. Maternal glucose crosses the placenta, but maternal insulin does not. The fetal pancreas hypertrophies to produce its own insulin. 2. Upon birth, the sudden cutoff of maternal sugar paired with high fetal insulin levels causes severe, life-threatening neonatal hypoglycemia requiring immediate feeding.
Yes, feed them right away.
3. Acute fatty liver in pregnancy is a maternal mortality emergency characterized by profound sickness, vomiting, and acute liver failure. 4. Intense itching on the palms and soles without a rash is the hallmark of intrahepatic cholestasis, which requires bile acid monitoring and early induction due to the high risk of sudden fetal cardiac death. And 5. Cocaine and tobacco cause profound systemic vasoconstriction, acting as massive triggers for chronic fetal growth restriction and acute placental abruption.
Those pathophysiological links are absolute gold for passing prioritization and clinical judgment questions.
All right, let's take a breath and synthesize this massive clinical journey. We have covered a staggering amount of pathology today, from the ectopic drill sites of the first trimester to the hypertensive vascular spasms and the toxic bile acids of the third.
We really covered a lot.
We did, but I hope, as we've walked through this, you can see the underlying patterns: hemorrhage, hypertension, and infection. These are the unholy trinity of obstetric nursing. Your job as a nurse, whether you are staring down a multiple-choice NCLES question or standing at the bedside of a laboring patient, isn't just to memorize a list of symptoms in isolation.
No, not at all.
Your clinical mandate is to recognize the exact physiological moment an expected finding of pregnancy crosses the threshold and becomes a concerning emergency.
And that requires deep clinical judgment. It requires understanding exactly why the blood pressure is high, why the abdomen feels like a wooden board, and why the baby's heart rate is suddenly dropping. When you understand the cellular mechanisms, you don't have to memorize the nursing interventions. The interventions become obvious, logical necessities.
I want to leave you with one final thought to mull over before your next exam or your next shift. We've talked a lot about the spiral arteries today, how their failure to remodel causes preeclampsia, leading to systemic endothelial damage. For decades, the medical community viewed preeclampsia strictly as a pregnancy complication. Once the placenta was delivered, the cure was achieved, and the danger was over. But modern pathology is revealing a much darker, longer shadow.
It is a profound shift in how we view maternal health.
The physiological stress test of preeclampsia, that massive systemic vascular inflammation and endothelial injury, doesn't just vanish. A mother who develops severe preeclampsia is not just experiencing a complication of pregnancy. Her body is revealing a fundamental vascular vulnerability.
It's a lifelong marker.
Yes, studies now show that these women have a drastically heightened lifelong risk of developing chronic hypertension, ischemic heart disease, and suffering fatal strokes 10, 20, or 30 years down the line. Her cardiovascular architecture is permanently altered by those 9 months.
Which fundamentally changes the role of the OB nurse.
Exactly. When you are discharging that preeclamptic mother on the postpartum floor, you aren't just handing her a baby. The education you provide her about her blood pressure, her future diet, and her need for lifelong cardiovascular monitoring isn't just about recovering from childbirth. You are initiating primary cardiac prevention that could literally save her life decades after she leaves your unit.
That's powerful.
You are navigating the muddy waters of a shared life force, and the ripples of your care last a lifetime. Trust the pathophysiological patterns you've learned today. Trust your preparation. And go out there and think like the fiercely safe, elite clinical nurse you are becoming.
You've got this. Keep connecting the dots.
We'll catch you on the next deep dive.